Hello, everybody, and welcome to the Hughes Clues Hypoxemic Respiratory Failure with Mechanical Ventilation. We're also going to cover ARDS, Adult Respiratory Distress Syndrome, Neuromuscular Blockade, and VAP. A very busy presentation, but it's also very important. All right, let's look at our case study, which is going to consist of a 20-year-old college student who's found unconscious by his roommate. He's brought to the emergency department, he's intubated at the scene, and mechanical ventilation was initiated on arrival to the hospital. The critical care nurse, that's you, is going to or did get report from the emergency department nurse that during the process of intubation, vomitus was suctioned from his upper airway. And when we look at our subject, he's been placed on mechanical ventilation while he's in the intensive care unit. And the kind of ventilation he's getting is volume ventilation in assist control mode. His rate's at 10 breaths per minute. Tidal volume is 650 mils. The FiO2 or supplemental oxygen is set as 100%. And then the PEEP is 5 centimeters. So let's do somewhat of a review as we describe the vent settings. And so what would happen if this patient tried to initiate a spontaneous breath? So this is kind of a review so that you understand that the ventilator is set on volume ventilation with assist control. And so the ventilator is going to, at a minimum, deliver a preset respiratory rate of 10 breaths per minute with a tidal volume for every preset breath at 650 mils. If the patient wants to attempt to breathe, they absolutely can, but as they attempt to breathe, the ventilator will sense the start of a spontaneous breath, and then the ventilator is going to deliver that preset volume of 650 mils. So at the least, the patient will get 10 breaths. If they breathe 2 breaths on their own or they attempt to breathe, they will also get the 650 mils at a total of 12 breaths per minute. Again, in assist control mode, the breath is initiated by any breath that's initiated by the patient is completed by the ventilator. So this patient's not doing any work of breathing at all. Now, what about that tidal, or the FiO2? So when we talk about FiO2, that's spontaneous, or not spontaneous, but supplemental oxygen. And we know that room air is at 21%. So supplemental oxygen totally at 100% means that it's at the highest amount possible. So we can see that in general, we do want to use the least amount of oxygen for the least amount of time, but the goal is always to ensure that a PO2 is greater than 60. Now, I know that this is kind of at odds with what you know. If normal PaO2 is anywhere between 80 and 100, what the heck? 60? Well, just know that it's not really what I would say a textbook normal, but in the course, Dr. Reed says in various places in the notes that the minimum goal is 60. In other words, for any patient on the planet, if the PaO2 gets less than 60, then they're essentially not compatible with life. And so in some patients, they're so critically ill that you get down on your hands and knees and thank the Lord that PaO2 of 60 is present. So again, I wouldn't use this as a standard in your clinical practice, but I would use it as a standard for your critical care course and or tests. Now, what about the SpO2 that I'm saying? Well, it's got to be 90% or greater. And again, that doesn't jive with what you learned in J2. And it's not going to jive on standardized tests such as NEATI or NCLEX. You want like a 95%, I think is what your course is. But again, in critical care, we kind of set the bar a little lower because these patients are really sick. And so I'm telling you, I don't think it's anywhere in the notes where Dr. Reed will list at 90% as normal. But having reviewed 30 tests over all the semesters I've been doing this, 90% is considered okay in the critical care course. So anything less than 90 is not good. 90 and above is okay. Sure, we'd want it higher, but we will accept 90. All right, then we also have as our vent setting a PEEP of 5 centimeters. So let's look at the ABGs that have been drawn on this patient after they've been stabilized in the ICU on the ventilator. And we see that the pH is 7.38, PCO2 36, bicarb 22, oxygen PaO2 is 57, and the O2 sat is 88%. So let's analyze the ABGs and let's identify a possible problem. So when we look at these ABGs, we see, yay, pH is good, PCO2 is good, and the bicarbonate's all good. So we know that the ventilator rate and depth, or the tidal volume, is okay because CO2 is being removed and the patient's bicarbonate's normal. Okay, so the kidneys are doing what they're supposed to be doing. So now we also then look at what's happening with the PaO2, and we see that it is not at 60 and it's definitely not at 80. So this is a very critical situation. The oxygenation status of this patient is horrible. So PaO2 is low and the SpO2 is low. So what kind of changes are we going to make? Well, if you thought, well, let's increase the supplemental O2, well, that's not going to work because we're at 100% and we cannot go any higher. So this is what we call refractory hypoxemia. You have a low oxygen state in your patient in spite of the max delivery of oxygen. So where do you go from here? So, I always forget to do this. Sorry guys, but anyway, we've got it. All right, so where do you go from here? So what changes to the vent setting would you anticipate? Well, we can't increase the supplemental O2, and so the only thing we can do is change. So here's your new rule, that if there are oxygen issues, you either increase the supplemental FiO2, which in this scenario is not going to happen because he's already on the highest, or you increase the PEEP. PEEP stands for positive end expiratory pressure. We know that PEEP norm, or what you and I breathe spontaneously, is somewhere between a 3 to 5, so that's normally what patients are placed on when they're on a ventilator setting. So in this scenario, because we cannot manipulate the FiO2, it's already at 100% at its highest, the only thing we can change to improve oxygenation status is to increase the PEEP. Let's go up to 7. And you might think, 7? Well, wow, why be generous? That's not much. Well, it is in PEEP land, because going up incrementally to 7, just a little bit above normal, actually does make a big difference, 7, 8. So it is a big difference. Now, what happens to the patient when PEEP is increased? In other words, what are the advantages and disadvantages of PEEP? So I'm going to say, without putting a little red alarm bell on there, warning, warning, this is a very important slide. You better know this slide. So let's look at both sides of the equation. What are the advantages to PEEP? Well, what happens is let's redefine what PEEP is. It's keeping the alveoli open. So we say that the advantages of PEEP is that we have what's known as alveolar recruitment. And I put down on the bottom what the heck that means, because of course we always have to use fancy words. It just means keep the alveoli open longer, or at the end of expiration, positive end expiratory pressure, keep it open longer so that gas exchange can occur. And that, again, is the second advantage, is that there's improved gas exchange by keeping the alveoli open longer and recruiting those that maybe were a little bit slammed shut. So you've got open alveoli, which improves gas exchange, and then it also decreases the work of breathing. And again, that might say to you, wait a minute, this is on the end of expiration. How does that help? Well, remember that at the end of expiration or exhalation, that with the alveoli still staying slightly open, it'll be much, much easier to inhale. So get that party balloon out and inflate, 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 then deflate, leaving a portion of that balloon open. And then when you inflate again, you're going to say, hey, that was a piece of cake to blow up that balloon again. That's what it means. And then, of course, maybe not in this scenario, but in a general scenario, if we increase the PEEP, we can reduce the supplemental O2. Now, I've said before that the more oxygen the patient is on, the more supplemental oxygen the patient is on, it can be harmful. It's a drug, and we don't want to keep that patient on 100%. I don't know I can't remember where Dr. Reed says you don't want it over 50 or 55%, and you don't. You just don't want any long-term increase in supplemental O2. 40%, no big deal, or less. But anything over 50 and above, you just don't want that patient to have that for very long. Now let's talk about the things that are disadvantages. Big, big, big thing for you to know. The disadvantages of PEEP are decreased venous return, decreased cardiac output, and barotrauma. So we're going to talk a lot about the disadvantages more. So here we go again. We have the advantages of PEEP. And so read this because I've already said it. We know that if we keep the balloon open for longer, then the oxygen will be exchanged better, and then it's the work of breathing. Again, look at your goal. The goal is to ensure that the PO2 is greater than 60 and the SpO2 is greater than 90%. Now let's talk in detail about the disadvantages. So one of the first things I said was a disadvantage was decreased venous return. So why? So I want you to think about physiology again, normal physiology where the diaphragm drops down, chest muscles are popped out with the rib, help with rib motion. And so this increases the diameter of our thoracic cavity, and inside the thoracic cavity is normally negative pressure. Inside the thoracic cavity is normally negative pressure. And when you increase the size of the thoracic cavity by pulling up chest and out and up, then that will even cause that negative intrathoracic pressure to go be more negative, less positive, even more negative. And what that does is create a vacuum. And then that's how we suck in air into the lungs, because if you think physics, the atmospheric pressure is at 0, and then inside your chest cavity it's negative something, and so that will just suck air into your lungs. Okay, that you probably remember this. But at the same time, what you weren't told is that that negative intrathoracic pressure will also suck up blood to return back to the right atrium. And you might think, oh, I didn't know that. And I didn't either until I started teaching this course. But you got to remember that venous blood that's returning from the feet has to overcome gravity. And there's several different mechanisms that help the blood overcome gravity. And one of them is negative intrathoracic pressure. So yes, on inspiration, air is sucked into the lungs and blood is sucked up from our feet and into the right heart. PEEP, positive pressure. You're adding positive pressure, which means you're getting rid of all that helpful negative intrathoracic pressure. And so the vacuum to suck in air is gone. No big deal. The on the ventilator, air is being shoved in. We don't worry so much about that, but we do worry about the fact that that negative intrathoracic pressure that's now gone or definitely lessened means that there is less venous return. Now, normally with a PEEP of 3 to 5, that's usually not a big deal. However, when you start incrementally increasing it, we've gone up to 7, now we have less venous blood that is sucked into the right atrium, which means less going to the left atrium. The cardiac output can go down, and so can the blood pressure. What about barotrauma? That was another disadvantage. So, of course, 2 of the disadvantages was decreased venous return, which can ultimately lead to a decreased cardiac output. And then the other thing is barotrauma. So there's 2 kinds of trauma. There's volutrauma, which means you shove too much air into the lungs. Well, that's not going to happen with PEEP. That's going to happen with the tidal volume amount. But barotrauma means PEEP is positive end expiratory pressure. You put a lot of pressure, and again, it's a physics thing. I don't get it. You physics people will. But you're putting a lot of pressure on that balloon, and pop goes the balloon when you put too much pressure in there. So this is the other disadvantage of adding all of that positive end expiratory pressure. And again, adding 2, making it from 5 to 7 is incrementally a lot in physiology land. All right, so we've got our volume ventilation settings, and there they are. And then I've just bolded the PEEP of 7 centimeters. So I've already told you what are the disadvantages. And how does that equate to you, the nurse? What's the big deal? Why would I even mention that? Well, because that's you, the nurse, the frontline woman, man, that is watching the patient. You have to identify the disadvantages because that's going to put your patient in jeopardy. So you have to know, hey, when I see these things, I got to report this to the physician and let them know, hey, you added the PEEP and the blood pressure went down. Or maybe the blood pressure is the same, but the heart rate went up. So we know that when the cardiac output goes down, the heart rate can go up and the blood pressure can stay the same. That's compensatory. I've talked about that a little, but you got to remember it. Now, what about barotrauma? How would you, the nurse, understand or be able to identify when barotrauma occurs? Well, great thing that you thought about that. So let's talk about it. So I've got this picture. And a closed pneumothorax just means that the patient's chest isn't open. And so your patient that we talked about had vomit, passed out from being drunk, and there's nothing wrong with his chest. It's closed. There's no wound there. And so when you have this pressure that's on the alveoli, so think of this space right here as a few alveoli clusters, and pop went their alveoli because of that increased pressure with PEEP. And so what does that do? Well, it's like a tire. It creates a hole in the alveoli or alveoles, whatever, lots of them, a few of them. And air, when it goes in through the ventilator and into the lung, it's going to leak out through that small hole. If you have 5 alveoli that are popped, then it's going to leak out into the pleural space. And this is not going to happen immediately, but as time goes by and that air is being pushed in, pushed in, pushed in, with each breath, you're going to have this collection of air in the pleural space. And that's what's known as a pneumothorax. Pneumo is air within this thoracic or parietal, between the parietal and visceral pleura. So in that pleural space, that's where air is going to start collecting. And then, as I said, as more breaths are taken, there's going to be more and more and more air, which is positive, and it will cause the whole lung to collapse. How do you know your patient has some kind of pneumothorax? What is the key on the exam? Well, you're going to have unequal breath sounds because you, the nurse, when you check those breath sounds, I can't remember what Dr. Reed says, but I think it's every 2 to 4 hours. You're going to hear sounds on this side because air's going in, but then if you don't hear sounds on this side, that should be your first clue that your patient has a pneumothorax. Now, what happens if you are a ding-dong nurse and you don't listen to those lung sounds regularly, and this patient develops a pneumothorax at 8, and you were busy and you didn't bother to listen to your patient's lungs, and air has been filling in this space, causing that lung to collapse. Even though it's collapsed, leaking air is still going into the pleural space. Where's it going to go? Well, it's going to start pushing on this space here. And it's not drawn in there, but what's in that space? Well, that's the heart. So that means when air starts collecting more and more and more, your pneumothorax, the most dangerous thing is that it can become a tension pneumothorax. Now, again, you can see in this x-ray here that you've got air within the lungs, but here you can see how this side with air filling up the space, it's starting to push the heart structures over. So again, a left-sided pneumo that then becomes a tension pneumo, which just means that there's so much air within this pleural space that it's pushing against the heart structures, just as if you were in a tight space with another person. Well, we all want to survive, so you're going to push that other person. Well, the lungs will push against the heart. This will also cause a massive drop in the cardiac output. So again, what nursing assessments would you expect? Diminished breath sounds. So I say diminished breath sounds, but I want your brain to go unequal breath sounds, because unequal breath sounds on one side should be your key that a pneumo's developing. Subcutaneous emphysema. Subcutaneous air, those are the same things. That's under the skin, that's air under the skin. So let's look at this picture here, and we see that we have a pneumothorax, a tension pneumothorax, because you can see the trachea has kind of been pushed over. So what happens? Well, physiologically, this air is here, and the air says, well, I'm not really happy in this crowded space. I think I'm going to try and leak out somewhere. And so it can actually kind of leak out. Again, another physics thing. I don't get it. Trust me when I tell you it happens. Air will just kind of ooze into this subcutaneous space. And it is known as subcutaneous emphysema or subcutaneous air. And you, the nurse, can identify it by feeling this kind of a snap and pop when you touch the skin. What do I mean by that? So if you get a baggie and put Rice Krispies in the baggie, a few of them, and then put a lot of air within that baggie, and then put it under, I don't know, some kind of rubber, a balloon that's not inflated, and then press down on it. That's what subcutaneous air feels like. It's like the snap and crackle of Rice Krispies, but you're not hearing it, you're feeling it, because it's a weird feel. Once you feel it, you'll know it. Now, we all see that there's tracheal deviation, so you can see it in the x-ray, which you're not going to have access to as a nurse, but you can see it here. This guy's trachea is not midline. It's pushing over from the left side to the right. So the tracheal deviation will happen on the opposite side of the pneumo. Again, you got to remember that as that heart is just pushed and squeezed, then it can't inflate, meaning it cannot fill with blood during diastole, and therefore the cardiac output goes down, and the patient can have a cardiac arrest. So your assessment is key with this. All right, we sidetracked, so let's go back to our hypoxemic patient. And we've got our vent settings, which have been identified earlier, and then the ABGs are drawn after we've increased our PEEP to 7 centimeters. And we see that the ABGs are still not good, even though we've moved the PEEP up. And in addition to the fact that the ABGs aren't that great, our patient is still hypoxemic, we also notice that the high pressure alarm keeps sounding and that the nurse hears crackles in the lung bases. So putting all of these things together, again, the only thing we have right now in this patient, in our patient scenario, which was the patient who was intubated and who continues to have low oxygen states despite an increase in PEEP, despite 100% FiO2, has now got a high pressure alarm that keeps sounding and crackles that are heard in the lung bases. So what does this mean to you, the nurse, that's at the bedside? So let's talk about each one of those assessment characteristics, and we begin with the high pressure alarm that keeps sounding. So pause if you need to, because I have hit you with a lot of info. All right, high pressure alarm, what does it mean? Well, let's go back to our lungs and the alveoli. Whatever way you want to look at it, it's a party balloon. And when you blow up a party balloon, how much force or effort does it take to blow up that balloon? So it's the same thing for a patient. When the patient is initially placed on the ventilator, the respiratory therapist assesses how much pressure or force it takes for the ventilator to blow in air with each breath. So the assessment is done by the respiratory therapist on the admission or when they're first put on the ventilator. Now, if the lungs are young, like the college students are, then they're going to be stretchy. And you will not see the word stretchy lungs. You're going to see the word compliant. So I say compliant, you see compliant, you think stretchy. So the lungs are going to be compliant. And when the lungs are compliant or stretchy, then it's a piece of cake for that ventilator to push in air. Think of your party balloon. That's very thin, cheap rubber. You know, go to Walmart, get a cheap party balloon, and when you blow it up, it's not hard. If you have a balloon that has thicker rubber, then it's a little bit more effort to blow in that air. If the lungs are stiff, or you have an expensive stiff rubber party balloon, then you would say that the balloon or lung is less stretchy, or it could be considered non-compliant. If the lungs are non-compliant or not as compliant as a 20-year-old's, then the ventilator will have to use more force. I say a lot of force. That's not really true. It's kind of more force. You know that when you have a balloon initially, you put more force to it than when you blow it up and down after you've done it a few times. So it's more force when lungs are non-compliant. So as the respiratory therapist determines how compliant the patient's lungs are, then the respiratory therapist will set an alarm. They will set an alarm on the ventilator, and therefore, in our sample patient or our case study patient, the high pressure alarm is sounding because from the time of admission to now, the ventilator is sensing that the lungs are less stretchy when they were, and the ventilator's having to use more effort to blow in air. So there's resistance. So again, compliance and resistance are opposite concepts. If the lungs are stretchy, there's less resistance. It's much easier to blow in air. If the lungs are less compliant or non-compliant, then there is more resistance. So this patient's lungs are getting stiffer. They are becoming non-compliant or less compliant, and they are offering more resistance. And that's why the ventilator is letting you, the nurse, know, it's taking me a lot more effort to blow in air when I didn't have to have that much effort in the previous breaths. So this patient's lungs are less compliant, less stretchy or elastic, and they are offering more resistance to the flow of air from the ventilator. That's the cause of the high pressure alarm. Now, the other assessment characteristic we identified was that there's crackles. So what are crackles? Well, it just means that there's water, some kind of fluid, in the alveoli. So when we add these assessments together, that there's more resistance, there's less compliance, and there's crackles or water in the alveoli, plus the fact we cannot get the oxygen status up, so there is what's known as refractory hypoxemia. Then you add, this is key, the history of aspiration. The physician and the nurse should suspect ARDS, adult respiratory distress syndrome. Now, we see all of these assessments and hear all of these assessments, and you, the nurse, go, here's the deal, here's my assessment. The physician should order a chest x-ray, and when the physician looks at the chest x-ray, or nurse practitioner, then they're going to identify infiltrates. So again, put all those pieces together. When you put increased resistance, less compliance, crackles, refractory hypoxemia, the history, and now we see pulmonary infiltrates, then ARDS is confirmed. So all of those assessment characteristics identify or tell the physician this patient has adult respiratory distress syndrome. So what does the diagnosis indicate, and then identify other causes of ARDS? So adult respiratory distress syndrome, let's talk what it is. So it's caused by diffuse injury to the alveolar capillary membrane, and as a result of capillary damage, capillary permeability increases and fluid crosses into the alveolar space. When the alveolar space is filled with fluid, blood cannot be oxygenated. In addition, the alveolar cells that produce surfactant are damaged, and that damage of the alveolar cells is what lays down the stiffness or causes fibrosis and the less compliant, less elastic, and more resistance. So this right here, this whole paragraph, is what your pathophysiologic definition of ARDS is. I want to identify to you that I didn't talk about carbon dioxide. Why? Because it's not a problem. Carbon dioxide, for whatever reason, again, I'm sure it's a physics thing, if you want to go look it up, carbon dioxide diffuses much easier than oxygen moves in. So oxygen just can't swim through water in the alveoli, and then you add the fact that the cells are damaged that produce surfactant are damaged, and you just have a big mess in the alveoli. That's why your patient's not oxygenated. So who's at risk for ARDS? Well, look at the list. Sepsis, aspiration of gastric contents, that's our scenario. Pneumonia, multiple transfusions, trauma, shock stays, CPR, cardiopulmonary bypass, such as when the patient has open heart surgery, and near drowning. What do all these things have in common? Well, they're inflammatory disorders. So what causes that alveolo-capillary membrane to be more permeable? The inflammatory mediators that are released when all of these things occur. So look at this long list. This pretty much defines just about every patient in the hospital because they have some kind of inflammatory problem going on. So everybody's at risk, and you got to be aware. Now, what's the big deal? Well, it carries a 50% mortality rate. ARDS carries a 50% mortality rate. So if the patient falls within any of these categories, then you've got to be aware of it. And you need to look for it and watch for it and treat it very, very quickly because of this high mortality rate. So you can see, I don't care where you're working, whether you're in NICU, because they're always at risk because they're underdeveloped lungs, and then and that's neonatal ICU as opposed to neuro ICU in adults. Just about every adult's at risk because of the inflammation. Because of all the things we do to them in the hospital. So be in tune, because ARDS, if it's prevented by being aware, you want to get on it really fast. So otherwise, it's, again, mortality rate's high. So this, again, is just another definition of ARDS. This is a picture from another textbook that I like better than the one that we currently have. And just take the time to look at it. This patient has ARDS. And there's all the criteria. With a diagnosis of ARDS, pressure-controlled ventilation is likely initiated. This is a decision by the physician because this is a better mechanical ventilation for stiff lungs. And oftentimes the rate is usually rapid and the breaths are usually shallow. So you math nerds out there, do the math. If you do 10 breaths at 650 mils of tidal volume, that's 10 times 650 is 6,500 something. Well, now divide that into shallow breaths. You're going to have to give, I don't know, 200 breaths, and that's what happens with ARDS. They go to a different kind of ventilation, none of which you have to know. You just have to know that the technique for a very critically ill patient with ARDS can be very weird. They can do it very rapid shallow. They can use different gases. They can put them in what's known as the prone positioning, which is you flip them on their face, and then they're on this little rotary bed. There's several different options, none of which you have to know when you would use either one. You just need to be aware. Here's your key. Whatever mechanism the physician prescribes for a ventilator, what's the goal? Well, the goal is to oxygenate the patient, because think ARDS, oxygenation issue, whatever fancy things we're doing to this patient, we want a good oxygen status. So let's describe the difference between pressure-controlled ventilation versus volume. So we've already talked about this, but to reiterate, when we do pressure-controlled, we're basically just limiting the amount of volume, because we know that these patients, the volume is not good for them. Their lungs are stiff. It's very difficult for the ventilator to do a big volume and a few breaths. So what has to happen is we can do a lower tolerable volume with a lot more breaths. Now, I want you to think about it. If you're on a ventilator and you got that tube in to begin with, and now the ventilator is giving you, let's say, I've seen it up to 200 breaths at a very shallow rate. How comfy is that? Well, it's not. And so physiologically, the patient's very uncomfortable. And so what does the patient do? Well, they'll fight the ventilator because they're going to want to try and breathe. And what happens is they are not in sync or not in the same kind of status as the ventilator. And so the ventilator alarm keeps going off because the ventilator can't do its job when the patient's fighting against it. So most of the, well, let me not say most, I'm going to say all of the time, whenever we use these funky, weird, dramatic, aggressive modes of ventilating an ARDS patient, the patient's paralyzed and sedated. So what does that mean? Well, neuromuscular blockade is another way to say paralyze, and it causes complete muscle paralysis. The patient can't breathe, blink, move, communicate in any way, shape, or form. So neuromuscular blockade, here's your goals, helps manage high airway pressures, improves oxygenation, and allows for ventilator synchrony. So the patient won't fight against or breathe against the ventilator. And there are several different drugs that are neuromuscular blockade. Very difficult for you to remember all the drugs in this course, but if you look at NIUM, just like when you did your farm course, the ending should say to you paralytic medication. Now, as I said, paralyzed patients can hear, see, think, and feel. So you have to think about them as, imagine if you were buried alive. There's no way to communicate. You feel like you're not getting air. You're not being able to breathe. It's very uncomfortable. And so IV sedation and analgesia must be administered concurrently. In fact, it really should be administered before the physician gives the paralytic drug. Now, there are several different sedatives and narcotics for sedation. And commonly propofol is used, or I'm not even going to do trade names because you're not going to have it on the test. So propofol has a rapid onset, rapid metabolic elimination. Again, I've put all these things about propofol because in past tests, there is sometimes a question on this. I haven't seen it recently, but you just never know when this little weasel thing creeps up. So there's the information on propofol. Then analgesia or pain control may be accomplished by the administration of an opioid such as fentanyl. So again, when you're in the hospital setting, you're going to see a variation of different combos. Sometimes the patients are on a paralytic plus fentanyl and then an analgesic such as a benzo, such as Versed or midazolam. Sometimes they're on propofol alone. Sometimes they're on other combos. But the bottom line is, if your patient's paralyzed, they need to be sedated as well. So there is, again, your goals of neuromuscular blockade, and then sedation and analgesia goals. Again, why do I have this on a separate slide? I think it's important. Let's talk about our patient assessment. You're giving your patient a paralytic. So the medications for our case study are norcuron or vicuronium, propofol, and fentanyl. So how do you assess the effectiveness of the medication? The patient can't communicate with you. So how do you know that what you're giving is effective? So one of the things for the effectiveness of the neuromuscular blocking agent. So this is very important, that this slide is for the neuromuscular blocking agent mostly. And what we do to assess whether the patient is adequately paralyzed is we do this thing called the train of four. And it is just called the train of four because this little gizmo here, this machine, will give 4 bursts of electrical current. Now, the electrical current's very low, so it's not like you're really shocking your patient, but in your own sense, you are shocking them because it is some current, but it's very low. And it's delivered through 2 sets of electrodes, and you can see that the nerve is along this line, and that's why those electrodes are placed there on the pinky side. However, I will tell you that in the clinical facility that I go to, a lot of times it's on the forehead because there's also another nerve that runs along the temporal region. And so you'll see it on the forehead. It doesn't matter where it is, the unit will kind of decide. But anyway, 4 short bursts of electrical current. And as each of these bursts are done, you want to look and see if there is twitching. And what we want is we want the patient to have either 1 or 2 twitches. That means there is some muscle response because that nerve twitched or caused a twitch, but we don't want more than 1 or 2 twitches. And we don't want 0 twitches. So that gives you not a real wide range. It's 1 or 2 twitches. You don't want 0. You don't want 3 or 4. So what happens when you see 0 twitches? Well, that means that that nerve is not responding at all, and it's over paralyzed. So then you would reduce the paralytic agent. What happens if you see 4 twitches? Well, that means it's under paralyzed and you want to increase the neuromuscular blockade. So you got to kind of get this in your head because you're doing opposite things. Too little paralysis, then you want to increase the medication. Too much paralysis, you want to decrease the medications. And you might say, well, I need a physician's order. Well, when the physician writes the order for the paralytic medication, they'll give you a recipe, that you're going to do the train of 4 every 4 hours. And then when you do, here's what you do. So it's pretty much standard kind of fare in the ICU. Now, what about ensuring patient comfort? That's really difficult to assess because it's not like you can talk to your patient or ask them to blink. You can't do it. So there is a very fancy gizmo that I've seen at Baylor University Medical Center, and it may be at other facilities too, where they actually assess the brainwave of the patient. And so when the brain waves are too little, then they're over-sedated. When they're too much, they're under-sedated. But for the most part, it's really up to the nurse to kind of assess. And there are different scales. There's a lot of different scales out there that are used. One is the Ramsey, then there's some other ones. You're not going to be asked about those scales. Just know that there is a scale that can help you determine whether the sedation is adequate. And then the train of form is very specific for the paralytic agent. Now let's talk about complications from intubation, because critically ill patients who are intubated for longer than 24 hours are at a greater risk for the development of ventilator-associated pneumonia. And of course, why do I have to talk about this? Because it's a big thing for hospitals, because the morbidity and mortality associated with VAP is high for the patient. So that's not good for the patient, but we all know that hospitals are, let's say, somewhat in tune to the money. And if a patient develops a ventilator-associated pneumonia, then we know that the hospital's not going to get reimbursed by the insurance company. So, yes, patient care is priority, but we also know that it's a money game too. So, what about nursing measures used to prevent VAP? So, VAP best practices are what's known as the VAP bundle, and they're all listed here, and I'll let you read them. I think the biggest thing is the subglottic suctioning. Make sure you put a circle around that. A lot of students are confused as to what that is. We've already talked about the endotracheal balloon pressure keeping at its 15 to 25. And then, of course, the respiratory therapist shouldn't be changing vent circulator changes frequently. So let's talk about that subglottic that I said put a circle around it so you don't forget it. Now, this is a special endotracheal tube. This is only used at certain facilities, and it is a special hole that's above the balloon. So again, orient yourself. This is the end that's down here, that's inside the patient's trachea, that's blowing air into the lungs. There's the balloon. So the hole for the subglottic is right here, because if you think this is the patient's mouth up here, saliva and secretions can drip, 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 drip down, and then they'll sit on top of that balloon. So if the balloon becomes deflated, then bam, they can go inside the lungs and cause ventilator-associated pneumonia. And so what can happen is this hole right here is connected to this big tubing, and then this tube is connected to the suction, and so they can suck 24/7. Now, I don't know how effective this is, but you got to look at saliva. Saliva is pretty sticky, and it can be very thick if patients aren't well hydrated. So is it effective? I don't know what the research says, but it's done. So that's what that means. Note that the endotracheal tube prevents the epiglottis from closing. Your patient can't talk. The endotracheal tube, while inflated, does not prevent removal. In addition, although the endotracheal tube or cuff is inflated, oral and gastric secretions can leak. So that's why the head of the bed's always going to be up, because if you put it down flat, then you better hold your tube feedings, because if they aspirate at all, because they have a weak sphincter, gastroesophageal sphincter, then you're going to also have gastric secretions in the lungs. That's never a good thing either. All right, take a break, watch the video later. Feel energized with this YouTube movie. I think it's fabulous. It's fun. So watch it, get energized, and then come back and see me, because I have yet another pearls to relay to you.